So we've talked about switching immune modulating drugs. Let's talk about proteasome inhibitors next. We have some choices. We have ixazomib, we have carfilzomib, once bortezomib has been used in the past. What kind of patient would you use either of those two new proteasome inhibitors in, and how do you select them?
Well, I think the biggest difference, obviously, between these two is the administration, oral versus IV. So for patients where that's going to be an issue, the ixazomib would win for convenience. But beyond that, I think the ixazomib data have only been done in patients with prior bortezomib sensitivity or naive, as opposed to carfilzomib. There are studies that have shown activity even in bortezomib refractory patients, albeit perhaps a little bit less. And I think the head-to-head study of Endeavor K at 56 milligrams per meter squared versus VD showed superiority in terms of response, PFS,
so what kind of patients are you picking for either drug?
I think if it's somebody who has an aggressive, more than just a biochemical relapse, I would probably use K over I. If it was somebody who had more of a biochemical and it was a convenience issue, then I would use I.
Any difference of opinion with that? Sounds like, is it all about tempo and aggressiveness? Is age, comorbidity factoring into your choices? Amrita?
Well, I mean, I think Tom alluded to the fact you can give carfilzomib in elderly patients, but it doesn't necessarily mean you have to, and I probably would prefer in an elderly, more frail patient try IXA first.
In IXA being oral, it's really convenient. I have a lot of patients where I present them, here you can take an oral pill, or you can come once or twice a week for an IV, and they all select the oral pill. But like Ajai said, it really needs to be in patients that are bortezomib sensitive and carfilzomib sensitive. If they're refractory to any other PI, then ixazomib is probably not the right choice.
Yeah, that's how I make the decision. If I'm thinking bortezomib, then I use that as an option. If I'm thinking that I wouldn't use bortezomib in this setting, then I think carfilzomib.
Okay. Let's talk about the ARROW study. Who wants to take a stab, explain to the audience what they heard yesterday? Amrita, why don't we pick on you?
I knew I should have sat next to him. So the ARROW study looked at the standard bi-weekly dosing of carfilzomib, 20 and then 27 milligrams per meter squared, compared it to a weekly dosing of 70 milligrams per meter squared. It actually showed equal tolerability, which I admit surprised me in terms of cardiovascular events. It was about 3 to 4% with the weekly 70 per meter squared, and it actually showed a better PFS for the weekly. So I think it will be practice changing because one, it'll make us more comfortable to use 70 per meter squared weekly, including in older patients. And frankly, as Tom alluded to, that's been the biggest barrier I think for patients getting carfilzomib has been the dosing schedule.
Any other reactions to that study, Sagar? What do you think?
Yeah, I mean, I think certainly the data, the toxicity data is what really struck me, because sometimes 70 once a week can be a little bit tough to give. I think it's clear both from Endeavor at 56 twice a week and ARROW at 70 once a week that you can give these higher doses of carfilzomib with Dex as the partner. The question is, we don't often do that. And so if you're going to partner it with Len or POM or DARA, how safe is it to do that? And we have some trials that speak to that.
What a great intro to Dr. Chari's trial. Because there has been this notion that 70 weekly is not going to be the dose you can combine with lenalidomide or cyclophosphamide. You have to use a lower dose. But you showed some compelling data yesterday combining carfilzomib with daratumumab. Do you want to tell us about that a little bit?
Sure. This is the DARA carfilzomib dex arm of the 1001 study, which is a phase 1 study comparing the addition of DARA to various backbone drugs. And it showed that it was very safe. Really, we didn't see a lot of additional toxicities than you would expect from each drug. The rate of neutropenia was relatively modest. Grade 3-4 was about 20%, so I think that was an interesting safety signal. And
I asked you this already, but you didn't see an increase in infection, because I've been impressed with the hypogammaglobulinemia you get with those two drugs, but you didn't see any concern.
We didn't see significant infection.
How many patients were there on this?
This was 85.
Still?
Yeah.
Big group.
And I think the interesting data also were that the PFS for the entire group was not even reached with a median follow-up of 12 months. But specifically, as Tom alluded to, the Len refractory population, the median PFS was 14 months, which I think in the context of the other data that we do have with DPD, DVD from Castor, and KD from Endeavor, this is a pretty encouraging result. And I think it adds to the ARROW study, which was the same weekly 70, and this is the same weekly 70 with the addition of DARA.
So is everybody switching to weekly carfilzomib? Is it done using it twice weekly? Are we still going to try that in some patients?
Well, immediately after the session yesterday, I sent an email to all the myeloma practicers at UCSF, including our pharmacists, and said, let's go to weekly for everybody, and let's get an Apex build and a Beacon build for the 70 weekly, because I do think it is certainly way more convenient than twice weekly, and patients will be very happy, I think, to go to that. I was very surprised also on the safety signal, that there wasn't a safety signal between 70 versus the 27 2 times a week.
Yeah, I think we were all a bit surprised by that, and some real life experience might.
You know, the other thing that struck me from that trial, which you can say is neither here nor there, the 2027 PFS was identical to VD in every other phase 3 trial. So I think if, you know, there are differences between the proteasome inhibitors, but if you look at the lower dose of CAR, it's basically equivalent to VD. I think
that's a really important point, because carfilzomib is not the same drug at different doses. Carfilzomib 2027 versus the Endeavor 56, I think you can't extrapolate that it's the same, and really to see that potency of higher doses is, I think is an important finding.
But I think the other point is sort of what you alluded to. It's sort of the same story as bortezomib, right? When we first started using bortezomib, we had a lot of neuropathy because we didn't know how to use it. With carfilzomib, we're recognizing you have to mitigate all these other factors first before you start a patient. So I mean, before you start to jump to 70 per meter squared, you really need to make sure everything else, all your ducks are in a row, in terms of hypertension especially.